We are performing transthoracic echo. Of course, ECG guided. It's mandatory due to systolic or diastolic period or time that can correlate ECG wave. So that ECG is mandatory, and the patient's position, of course, suitable condition and suitable position, and also comfortable position, and room also comfortable. And here just a peristernal left peristernal long axis view. We have it's a pretty good to look the left atrium, and seems to be dilated, and seems to be AML and PML non-copted, and LV dilated. There is a reduce the thickness of the interventricular septum, also in posterior inferior wall, and there is just thin layer of pericardial effusion as well. And this descending aorta or this one descending aorta, we have to identify which one is descending aorta or coronary sinus. And the coronary sinus usually the base of the PML. So this is the coronary sinus, also dilated, and this is the descending thoracic aorta. Coronary sinus dilatation, all of we know the persistent left superior vena cava congenital anomalies causes the dilatation of the coronary sinus. But most common causes of dilatation of the coronary sinus, congestive heart failure. You have to keep in mind. And here so left peristernal long axis view, which the structure we can identify. So left atrium and the mitral valve, AML, PML, and the aortic valve, and two cusp, and also proximal part of the aorta, annulus, and there is a sinotubular junction and proximal part of the root of the ascending aorta, and there is a LVOT dimension, interventricular septum, LV. If you consider LV, then interventricular septum, and there is a posterior inferior wall. There is a right ventricle and right ventricular free wall, and this is the epicardial fat, and this is the pericardial fat, small amount. Now just pointer towards the left shoulder. It's the peristernal short axis view at the level of base of the papillary muscle. There is a rocking movement, there is a jerky movement of the apex and septum as well, and there is a reduced systolic thickening. There is a just rotate rocking, but there is no thickening during systole. We have put the M-mode cursor over the left ventricle, then we can easily identify the thickness. Here the thickness is reduced. This is the diastole, this is the systole. Here also there is a discordant between the time of posterior wall and also interventricular septum. Here is the systole, but here is the systole, posterior wall. So there is no concordance. There is a delay between the systole of interventricular septum and also posterior wall. When the LV is dilated, or in case of left bundle branch block, it is invariably we have to found that this type of movement of the left ventricle. And now I like to obtain the apical four chamber view. Apical four chamber view, here we have to see in the, just put the color, and there is eccentric MR. Sometimes it's called the Coanda effect, and the eccentric MR, usually eccentric MR at least moderate. Here we have to see the vein, pulmonary vein, up to pulmonary blood, pulmonary vein. So it's the severe mitral regurgitation due to ischemic. It may be due to papillary muscle dysfunction, it may be due to annular dilatation. At first the papillary muscle dysfunction, and when the hugely dilatation occurs, that the annular dilatation causes the MV non-coaptation and producing the mitral regurgitation. and also we have to see in the tricuspid regards, but not to the severe as the mitral regurgitation. Here thus mild to moderate tricuspid regurgitation. Here interictal septum just show the echo dropout, but not due to ASD. There is no color passes, and sometimes misguided there is echo dropout. It's not echo dropout. We can easily obtain by our probe rotating or movement and disappear. Echo dropout, just not echo dropout, we can tell the ASD is present. So we have to obtain the several view. Here the easily interictal septum intact. Okay, and the another thing is the when the interatrial septal defect, in that case right sided volume overload at first and then pressure overload gradually. It's very much important. And subcostal location and apical 5 chamber view, we can identify the ASD very much easily when the doubt in the apical 4 chamber view. Now we have to try to obtain apical 2 chamber view. Here movement of the anterior wall and also inferior wall. This is the anterior wall, this is the inferior wall. So here to some extent movement is maintained, but this wall movement is reduced, significantly reduced. And in this view also we can easily find out the mitral regurgitation. So dense, so severe MR. This is the apical 5 chamber view. When the aorta is identify and right atrium, right ventricle, left atrium, left ventricle and aorta, then it's the apical 5 chamber view. Now apical 4 chamber view. And when the apical 5 chamber view, just rotation or sometimes the put the button left or right, then easily we can obtain the apical 3 chamber view easily. Okay, thank you.